Hello and welcome to CLP's webcast, How Clinical Laboratory Alignment Will Improve Critical Bleeding Management, sponsored by Hemosonics. I'm Chris Wolski, CLP's Director of Business Intelligence, and I'll be the moderator for today's presentation. At the conclusion of today's presentation, we will have a short Q&A with the webinar's presenter, Dr. Jonathan Chow, who I'll introduce in a moment. Please, at any time, feel free to submit a question via the Q&A box on your screen. Those questions that aren't answered will be addressed directly by Dr. Chow and the Hemosonics team after the conclusion of the webinar. Today's webcast is being recorded, and you will receive an email tomorrow with a link to the recording. It will also be available to new registrants to watch on GoToWebinar for the next 3 months. So if you know of anyone who missed it, they'll have a chance to watch the webinar over the next 3 months. Now, it's my pleasure to introduce you to today's presenter, Dr. Jonathan Chow, who is an associate professor at the George Washington University in Washington, D.C. He is an expert in the fields of critical care medicine, anesthesiology, and resuscitation. Dr. Chow currently serves as the chief of the liver transplant anesthesiology program and has expertise utilizing multiple forms of viscoelastic monitoring for coagulation management. So without further delay, I'll hand the baton off to Dr. Chow.
All right, well, thank you very much for having me today. It's a pleasure to speak to this group about how clinical and laboratory management will help improve critical bleeding in trauma. Specifically, we're going to be talking about trauma care and advanced coagulation monitoring techniques. For full disclosure, I am a consultant for Hemosonics, who is the manufacturer of the Quantra device, but nevertheless, we're going to stick to the science and the evidence that is available in the literature. So acute coagulopathy in trauma is a major problem, and this is a problem that is associated with very high mortality in traumatically injured patients. Specifically, patients with acute traumatic coagulopathy, a 8.7 time increase in the odds of dying in the hospital. So early recognition and management of this coagulopathy is critical for outcomes, especially in trauma resuscitation. We've had several different papers that have come out over the years addressing the use of blood products and the specific ratios of blood products for traumatically injured patients. And most of these studies have shown that the median time to hemorrhagic death occurs within the first 2.3 to 2.6 hours. So the clock really starts ticking as soon as your patient becomes traumatically injured, and time is of the essence for you to resuscitate and to address any issues with coagulopathy within this time frame. Now, in the operating room, amongst anesthesiologists and surgeons, we are very cognizant of the triad of death, which is the combination of hypothermia, acidemia, and coagulopathy. And the presence of any one of these entities is lethal because it will then propagate and make acidemia worse. It will make coagulopathy worse. It will make hypothermia worse. And then ultimately, it will make it more and more difficult to get out of this vicious cycle to successfully resuscitate the patient. Now, over the years, we have developed massive transfusion protocol guidelines where clinicians are protocolized to automatically transfuse blood products in a one-to-one-to-one fashion. And over the past couple of years, with the development of viscoelastic monitoring, we found that patients who are resuscitated with a viscoelastic-guided technique actually have better outcomes than patients who are transfused with a standard massive transfusion protocol. This study was done at Baylor University. They found that 30-day mortality was significantly reduced in the viscoelastic-guided group, as well as 24-hour mortality. And the reduction in mortality was mainly due to the significant decrease in the volume of FFP that was transfused in the viscoelastic group. And this is because viscoelastic guidance, it really prevents unnecessary pre-prescribed transfusion of FFP, because you can look at your clotting factor values and determine whether or not FFP is actually indicated in that situation. Now, transfusion of plasma and FFP is generally not good for patients, especially if they receive a non-massive transfusion. This was a study done at USC as well as at the US Army Institute of Surgical Research, which found that there really was no survival benefit with FFP transfusion. And in fact, patients who received FFP had a significant increase in the rate of complications. They had an increase in the rate of ARDS, multi-organ failure, and then also pneumonia and sepsis. So if we could avoid FFP where possible when it's not indicated, it may be beneficial to only transfuse just enough FFP that is necessary. Now, we use conventional coagulation tests every day in the hospital, and these are the regular coags that we get, such as PTT, PT, INR, platelet count. And these tests are conventional tests that are static tests. They measure the coagulation cascade at a single point in time, and it's not dynamic at all. And these tests take a long time to come back, and they may not necessarily be truly reflective of what's going on in the coagulation system. For example, D-dimer, which is kind of the surrogate for fibrinolysis, is not a very sensitive nor specific test, because many patients in the hospital will already have D-dimers that are elevated regardless of whether or not fibrinolysis is present. Now, contrast this with a viscoelastic. Viscoelastic tests are relatively fast, and they are dynamic tests of the clotting cascade, where you're able to measure and see the clot initiation over time. You're able to see the clot strength over time, and also the stability of the clot over time. And ultimately, by looking at the values and by looking at the graphs, you're able to see the actual kinetics of the clot as the entire clot forms, and then as the clot breaks down. Now, the big difference in the capabilities of this test between conventional coagulation test and a viscoelastic test, I look at it as the difference between trying to land an airplane in clear weather versus trying to land an airplane in the clouds. So on a clear sunny day, if you're a pilot flying a 737, you can see the runway from 10 nautical miles away. You can see exactly where you're going to land. You know if your airplane is to the left or to the right of the runway. You know if you're too high or too low. And you know if there's any obstacles in the way. And you can make a nice, smooth landing just by visualizing it with your own eyes. But as soon as there are clouds in the sky that start to obstruct your view of what is down below, things start to get a little bit more fuzzy. You may know that the airport that you're trying to land at may be 7 nautical miles away to your northwest, but you don't know exactly where that runway is, and you don't exactly know if there is a building or a tower that is in your way. You can't see the air traffic below you, and no pilot would ever descend below these clouds without some sort of guidance system to help them safely land that aircraft. Now, fortunately, when you and I go to the airport for vacation or for business trips, the planes aren't grounded on the ground every time there's a cloud in the sky. And that's because pilots are able to rely on an instrument landing system to help them guide them precisely to the center line of the runway. And all of this data gets displayed on the pilot's instrument primary flight display, and they are able to see with the localizer whether they are too far to the left or to the right of the runway. In this case, the runway is to the left. They can see with the glide slope whether their aircraft is too high or whether they are too low. In this case, they are too low. And they're able to rely on RNAV waypoints, which are very precise measures of GPS coordinates, to fly a precise landing and approach path into the airport, even through the clouds with thunderstorms on a rainy day. Now, taking this analogy and bringing it back to the operating room and into the hospital, the Quantra system is the instrument landing system for hemorrhagic shock. You get a patient that comes in through the emergency room. They're cold, they're 32 degrees Celsius. You don't know how much blood they have lost out in the field. You don't know how cold they're going to be. You don't know how much blood they're going to lose in the operating room. And you don't really know the state of their coagulation system. And the Quantra, similar to an instrument landing system, is able to provide values to the clinicians to show them exactly what is going on with the coagulation cascade and what they can do to intervene and fix it. So up on the top, we have several values. The CTH is the clotting time with heparinase. We have CT, which stands for the clotting time. We also have the CTR, which is the clotting time ratio, and I'll go over that in a second. Other data points that the Quantra will display on the screen are the CS, which is the clot stiffness. You can also see the platelet contribution to the clot stiffness, and then you can also see the fibrinogen contribution to the clot stiffness as well. And then with certain cartridges with the Quantra, you can also see the stability of the entire clot to lysis as well. And the way that this display is designed, it's designed in a very graphical dials manner. So you have your reference ranges, which are in the green bars right here. And when the values are within the reference range, you have an arrow in white, which will show you what that value is. But then as soon as your values start falling outside the reference range, the arrow will turn yellow. And then you'll also get a little alert on the side, which is the yellow exclamation point, which will cue you to the fact that this value has fallen outside of your reference range. Now, this device is critically important to us at GW for our liver transplant program. So important that we have positioned the Quantra so that it's in the operating room itself, right next to the anesthesiologist. So when I'm doing a liver transplant, I am able to draw my labs directly from the patient's arterial line with my right hand, and then I take 3 steps over, put the sample in a light blue top, and I'm able to put it directly into the Quantra machine, and 13 to 15 minutes later, I will be able to get all of those values on my coagulation cascade so that I can intervene 13 to 15 minutes later. Now, this device at GW, the way it's set up as a point of care device, and the lab will maintain the device. So every 30 days, there is a wet QC that our laboratory techs will come up and perform. And then every time I turn on the machine and every time before a sample is run, a automatic QC will also be performed by the device itself without me as the user having to intervene. Now, interpretation of the Quantra values is also very straightforward. So as I mentioned before, we have the CTH, which stands for clotting time with heparinase. The H is for the heparinase. We have CT, which is the clotting time, and that represents your level of factor function in your coagulation cascade. And then your CTR is your clotting time ratio, which is your clotting time divided by your CTH. And that will allow you to see whether or not there is a heparin effect that you could potentially intervene with protamine to reverse the effects of heparin. Now, out on the bottom of the screen, we have the PCS, which is a platelet contribution to clot stability. So P equals platelets, and if you're outside of this range, it suggests that maybe your patient may benefit from additional platelet transfusion. And then FCS stands for your fibrinogen contribution to clot stability, and then the F equals fibrinogen. So if my FCS is very low, then potentially I may intervene with fibrinogen concentrate or with cryoprecipitate transfusion. Now, the QStat cartridge was a cartridge that was FDA approved recently, and this allows you to measure hyperfibrinolysis in your trauma patient or liver transplant. And the L stands for lysis. And if you have a CSL value that is outside of your reference range, then you potentially may be able to intervene as well. For those of you who are used to looking at curves with viscoelastic testing, there is an option to view the curves as well, and that will also display the values alongside that with the curve. And especially for lysis, lysis is extremely important because primary fibrinolysis is associated with significant increase in mortality. In this study, mortality exceeded 60% in patients with primary hyperfibrinolysis versus less than 20% in patients who did not have fibrinolysis. And thankfully, we have drugs that are available that allow us to intervene whenever hyperfibrinolysis occurs. Now, taking a look at this antifibrinolytic pathway, you have plasminogen gets converted into plasmin, which is then converted into fibrin and then fibrin degradation products. Now, we have drugs that will enhance this pathway, such as TPA, these clot-busting drugs that we use for PEs and strokes. But we also have TXA and Amicar that will inhibit this pathway by binding to the plasminogen site itself to inhibit fibrin degradation from occurring. And there's plenty of evidence out there in the literature which shows that there is a benefit of utilizing TXA in trauma. And many of these studies were done out in the battlefield, specifically at Camp Bastion in Afghanistan. That's where the MATTERS and MATTERS-2 trial both took place. And in that trial, Johnny Morrison from the U.S. Army Surgical Institute, he was able to show that there was a significant increase in cumulative survival in those soldiers who received TXA. And this difference was magnified, particularly amongst the patients who were being massively transfused compared to those who did not receive any TXA at all. So Quantra is a form of viscoelastic testing. It is designed from the ground up with coordinated teamwork in mind, and that involves all personnel in the hospital, from your anesthesiologists and your surgeons to people in the lab to people in the blood bank, and it provides us an efficient and operationally sustainable solution to provide evidence-based bleeding management to patients who are in shock. The burden of compliance to the patient and the healthcare team is significantly lowered. There are a broad range of indications with the Quantra to help reduce current and future regulatory hurdles. This is a simple and cost-effective solution that includes installation, validation, support as well. I can tell you that when I picked the Quantra for our liver transplant program, I did it primarily because of the rapid return of results, and then also because of the operational efficiency, in that we were able to use this as a testing device in the operating room, so that we didn't have to hire additional 24/7 personnel to help, tube our samples down to the central lab, to walk the samples down to the tubing station, and it ultimately just increased our operational efficiency. In terms of quality control, there is a monthly liquid QC that our laboratory performs in the operating room, and they do that once every 30 days. But then every time you turn on the machine and before every time you run a test, there's an internal automatic QC that is done prior to all of those events so that you can stay in compliance as well. And then on the back end, this device will also talk to your EMR so that the results can be easily imported and merged into the patient's chart. So that is all I have for you today on the use of Quantra and viscoelastic monitoring in trauma and in liver transplant. And then with that, I will turn it over to the rest of the team for any questions.
All right, well, great. Thank you, Dr. Chow. This is very informative. I think I certainly got a lot out of this, and I'm sure our audience did as well. We do have some time left, so let's answer some of those questions that came in during the presentation. Now, if you haven't already, please input your questions in the Q&A chat box. This is, you haven't missed your opportunity to ask questions. So I have a multi-part question for you, Dr. Chow. So this person asked, our current vet is outdated. How would you recommend we go about evaluating the Quantra system? It sounded like you had some specifics that you were looking at and you really liked, but how would you generally evaluate the Quantra system? And what, in your opinion, are the key things that are important to clinicians, laboratories, and administrators? Are they the same or are they a little different?
Yeah, so that's an excellent question. And I think that the most important thing is to do this as a team. And there are multiple different stakeholders involved. It's not just the surgeon or the anesthesiologist. You need to get the lab involved. You need to get the blood bank involved. You need to get hospital administration involved. And all of those players need to come together at the table to evaluate the Quantra together to see how it will most benefit their hospital, because each different stakeholder has different needs. We ultimately all have the same goal, which is to help take care of patients. But I think my best piece of advice would be to get all of the different stakeholders sitting together at the same table to discuss their VET device.
Okay, and for you, I'm just going to add on. I'm just going to add extra on there. You mentioned what was important to you. So how did you make that evaluation yourself?
Yeah, I think
when you were looking at Quantra and maybe other devices.
Yeah, I think for me, I've had experience with pretty much all of the other VET devices were on the market through the three different institutions that I've been at.
Okay.
The primary important factor for me was going to be ease of use, number one. Number two, it was going to be time to get the result back. But then the third element was hospital personnel resources. And that was kind of the rate limiting factor for our institution, in that we did not have a dedicated 24/7 anesthesia tech that could run my Quantra samples or VET samples to the tubing station so that it could be sent to the central lab so that the lab could run it in the basement of our hospital. That solution just was not available to us because it couldn't be done in a timely fashion. And then there were also financial constraints between hiring a 24/7 additional personnel as well. And that is how I chose the Quantra, because it's really truly a point of care test where you don't need to pipette a sample in the middle of a liver transplant. You just don't have time to do that. You don't have 10 minutes to wait for the sample to incubate before you can run the test on the machine. You just need to be able to run it immediately. And that's how I picked the Quantra.
Okay, so for you, this was our next question. I kind of rolled this in here, but so when you're comparing it to some of the other vet devices that you were talking about that you worked with, how does the Quantra compare? Is that the key thing, that the comparison? It's just that the faster system, particularly for your case study.
No, it's really the rapidity of how quickly the lab result can come back from the time the clinician draws the blood sample. That's when the clock should really start. And
Right.
when I did that comparison, by the time I drew my patient's blood from the arterial line to when the actual result comes back, it's about 13 to 15 minutes with the Quantra. If I send out a different down to the central lab, you may have to wait 10 minutes for incubation period. You may have to wait for a OR tech to transport your sample down. And then there are a lot of operational delays that just aren't present with the Quantra the way that we've set it up here.
Got it. Got it. All right. So we have a question came in from, looks like an educator who's joining us. And the question is, where can I get materials about VET to use in the classroom? My laboratory science students need to know about these instruments for their certification exam. There's very little information in their textbook. Do you have any advice for this educator and their students?
Yeah, so there are online training resources that are available, and Hemosonics does offer a online and customizable platform for administrators and educators and users that they can utilize. And it's pretty much up to each site how they use it and whether they choose to use it or not, or supplement it to create it within their own program. But yes, Hemosonics does offer online resources for educators to use.
Okay. All right. So there are generally online training resources as well, correct?
Correct.
Okay, great. All right, so let's talk about the IT part of it. We talked a lot about the benefits of it. There's a question that came in. Does the Quantra system connect to the electronic health record, and are those results immediately available?
Yes. So I think one of the most important things is that there is a connection on the back end to your EMR, because
Right.
other clinicians besides myself are going to have to be able to see the Quantra so that they may be able to act on it in the ICU, pre-op or post-op. And it does connect to those middleware solutions so that they can talk to EMRs like Epic and Cerner on the back end. To integrate it within your current environment. And the way that it works is that the results will transmit from the Quantra device to the EMR, and then all the device users can be managed through a Active Directory that a administrator can manage. And then there's also local remote viewing that is available as well, which you don't need to install an additional server to do that. It's just a piece of software so that you can remote view your Quantra as the tracing grows in the operating room or in the lab.
Okay. So here's a question about implementation. We talked a little bit about IT, but let's just talk about learning curves now. So what was the learning curve for the Quantra, and how long did it take you to implement it at GW?
Yeah, so the learning curve, because of the way that Hemosonics has designed their graphical displays. So unlike traditional displays where you have to interpret this curve and then try and measure angles and see where the tangent of the lines are, they have designed the display so that it's a graphical dials display where there are reference ranges that your institution can customize and set. And because of that, it makes it very easy to interpret, because if your value is outside of the reference range that your institution sets, then you know there's a problem with that particular value. And then the way that they have designed the nomenclature also makes it easy to remember which item refers to what part of the coagulation cascade. So CSL, you have the L there for lysis, meaning that you have hyperfibrinolysis. Your PCS, P is for platelets, so that would indicate platelet problem with the coagulation cascade. And then F is for fibrinogen. So if you have a problem with that particular parameter, you know that you need to transfuse fibrinogen concentrate or transfuse cryoprecipitate, which has fibrinogen contained within it. So ultimately, very easy to train. Hemosonics provides a lot of training manuals. Personally, in my operating room, it takes me about 5 minutes to train an intern how to interpret the curves during
Wow.
transplant.
Wow. And how what was the implementation timeline? So training timeline sounds pretty short. What was the implementation timeline? Certainly you're integrating it with your EHRs and your other equipment in the operating room, et cetera. So how long did that implementation part, the physical implementation take?
Yeah, the physical implementation part, it took a couple of months because
Okay.
we needed to get all the key stakeholders involved. So the lab, the blood bank, hospital administration had to be involved. And I think a lot of the reason why it took a couple months was because of administrative issues, not because of clinical issues. So we got the green light to purchase the product. The device showed up within 1 to 2 weeks. The QC took very little time, and then we were pretty much using the device within a couple of weeks of actually receiving it.
Okay. Great. So we have a couple more minutes for questions. If anyone else has a last minute question, now is the time. I'll give everyone a couple of seconds here to maybe give us another question. Okay, it looks like well, we got through all of our questions. So that is the time we have for today. I'd like to thank today's presenter, Dr. Jonathan Chow and Hemosonics, for sponsoring today's event. I will also like to let audience, both our live audience and those who are listening to this as a recording, the slides will be available as handouts. Just look at the handout section on the dashboard, and those will be available once we post this online. So those of you who are attending live, you'll be getting a link, and you'll be able to go back in and get those slides. We will send all audience questions received, which we've already gone through, to the Hemosonics team if any come in after the fact. If you have any additional questions, please send them to me at webcasts. That's with an S, webcasts at Medcore. That's medqor.com, and I'll either pass those along or answer them if they have to do with CLP directly. If you have, we also like to know any comments. If you have questions or future webinar suggestions, we're always looking for ideas. Visit us, and then also visit us at clpmag.com and follow us on all of the major social media platforms. So thank you for taking the time to attend this CLP webinar, and I hope you all be well.